in this unit, having learned already about parasympathetic autonomic nervous system function, we're going to talk about the muscarinic drug classes, both the agonists and the antagonists. So for drugs that actually stimulate the muscarinic pathways, we have two general mechanisms. Those that act, they either look like acetylcholine, and those are muscarinic agonists, and usually are drugs that are not acetylcholine because, as we learned, it's broken down by the plasma cholinesterases. Or we have drugs that increase the amount. So they increase the amount of acetylcholine in the synapse by blocking its degradation. And so they are against the acetylcholinesterase. Okay, so we increase the amount of acetylcholine in the synapse, we basically have an effect that is much broader, and use the example of insecticides in this case, that are like organophosphates, that leads to broad, all the muscarinic effects of the body, and some nicotinic effects of acetylcholine are exacerbated. So let's talk about the direct-acting drugs. That means those that look like acetylcholine. The two that I'd just like to highlight here is they're basically prototypes of drugs. Bethanechol, and it's one we use in veterinary medicine, and it's stable to the hydrolysis of the plasma cholinesterase. And then we have, and it's used for treating things like bladder bladder dysfunction itself. We also have pilocarpine. It's a partial agonist against the muscarinic receptor, and it is used as a topical agent in conditions like glaucoma. Now, the indirect acting cholinergics, for the most part, we're going to categorize as acetylcholinesterase inhibitors. And so they can be broken down into those that are short-acting and intermediate acting. These are the ones that are most useful to us clinically because the irreversible ones, the organophosphates, generally are associated with insecticides, war gases, etc. So the ones that are most useful are short-acting ones. Edrophonium is used in treating glaucoma. Neostigmine, pyridostigmine, these are the carbamates. They're also more reversible in effect than the cholinesterase inhibitors. The organophosphates are more permanent effect. And so we can use these under controlled circumstances, usually topically, occasionally as a diagnostic tool in veterinary medicine. And as I mentioned, the irreversible ones, example being organophosphate insecticides or war gases. These are obviously very dangerous agents, and we have to understand what's going on there because some of our attempts to block the effects are going to be to try to block the muscarinic and the nicotinic effects of the increase in acetylcholine in these conditions. So the characterization of the clinical effects that you can see with the use of an overuse or a toxicity of an acetylcholinesterase inhibitor is what's called the SLUD syndrome. And that includes increased salivation, lacrimeration, urination, and defecation. And when you see these things together, you should be highly suspicious if the animal, whether the animal has taken in an organophosphate or been exposed to it topically. And of course, the real threat to the animal is going to be in its the eventual possible depolarization, block, and paralysis of the neuromuscular junction, because acetylcholine exists there too. So the acetylcholinesterases in that way are very nonspecific stimulants of all cholinergic pathways that involve the control of the musculoskeletal system and also the autonomic system. Now let's turn our attention to the anticholinergics or parasympatholytics or muscarinic antagonists. And I really am going to focus just on this group on the left. Ganglionic blocking drugs are those that influence this signal transduction within the ganglia of really all ganglia, both sympathetic and parasympathetic. So they're very non-specific drugs, and they're not used very much, if at all, in veterinary medicine. So what are the effects of muscarinic antagonists? And I'll go ahead and tell you that our prototype drug is atropine. And so what we're going to talk about here are atropine. So what we're going to talk about is the inhibition of secretions. We sometimes want this if we use it as a pre-op therapy. It can help us block vaguely mediated bradycardia. Why is that important? When you go into say a surgical procedure in the abdomen, you're tugging on things that are connected to the autonomic nervous system, and it may overstimulate the vagal nerve. The vagal mediated stimulation may drop the heart rate and therefore the blood pressure. We know that muscarinic antagonists can be used to cause pupillary dilatation, mydriasis. We use it clinically in ophthalmology to take a better look at the back of the retina. We know that one of the prices we pay is an inhibition. This is really important. Inhibition of GI motility. We'll get a relaxation of smooth muscle. Not really dramatic, but depending on the tone of the bronchial tree or the urinary tract, this is something we try sometimes, is to use muscarinic antagonists. And then we use muscarinic antagonists as antiemetics because they have an effect on the cholinergic transmission of the emetic center. And they also are involved with the vestibular apparatus and its transmission. And actually many of the drugs that we will learn are antihistamines really have side effects that overlap being antimuscarinic, and that's the reason why they are particularly good at managing motion sickness. So as I said, the prototype drug is atropine. We use it as a pre-anesthetic, and its goal, or a drug like it, glycopyrrolate is probably used more often now, is to reduce respiratory and GI secretions. In the case, the only change over in the case of glycopyrrolate is that it has less cardiovascular effects, less CNS effects, and that's a good thing. We use drugs for motion sickness. So you go on a cruise, you may have a drug like a patch of scopolamine put on to help reduce your nausea due to that motion sickness. That's due to inhibit the vestibular apparatus function. We will sometimes use drugs for treatment of asthma by inhalation, a drug like ipratropium, and it's been changed away from atropine to not cross cell barriers. When you go to the ophthalmologist, a drug named tropicamide is the one that often is put on topically. It's a shorter acting version of atropine. When you treat conditions where you want to reduce scarring of the ciliary, the iris, for example, in a horse, you might put that animal actually on atropine because it's longer acting and you don't have to administer it as often. So these are the common examples of muscarinic antagonists, and very quickly, many of the ways that we use them. And finally, and this is a general message of any use of a drug, but in this case, a drug affecting the autonomic nervous system, you're messing with Mother Nature. So as you start to try to influence one organ that you're really interested in, let's say you want to reduce secretions, you may find that what you're doing instead is leading to a blockade of the acetylcholine's effect on the heart that could lead to tachycardia. In the case of the control of the iris dilation, you may find as a side effect that you've increased intraocular pressure because those two things are related to the drainage of the anterior chamber fluid. If you have been treated by surgery and you're in a hospital, the very first thing they want you to do before you're allowed to leave is to urinate. And the reason for that is they want to make sure that you do not have problems urinating, and that it could be because they gave you a pre-op muscarinic antagonist. And finally, and this is a big important thing in species like the horse and even in cattle, but particularly the horse, is that if we use a muscarinic antagonist, and for this reason they're often avoided, you can get long-term atony of the GI tract. It's called ileus. That can lead to constipation, and that can lead to big trouble in those species that require not only the action of acetylcholine, but it to be be affecting the GI tract in a coordinated fashion, and you've taken that away.